请各位坐掌上啊。Please everyone to come here. So, good morning, everybody, my dear friend. Now we are starting our this section, and I'm Dr. Kang from Tainan, Cheng Kung University. So we have our panelists and the moderator to introduce yourselves.
Good morning. I'm Dr. Li from Tainan.
Hi, good morning, everybody. I'm Dr. Ting from China Medical University Hospital. Thank you.
Hello, I'm Dr. Xue from Hsinchu CNUH. Thank you.
From Medical University Hospital.
Hello, my name is Reza Juneri. I come from Indonesia.
Hello, I'm Steven Sun from Taipei Mackay Memorial Hospital, and I'm a cardiovascular surgeon.
Hello, I'm Dr. Min Long Cai from Tuchen.
各位同学大家好，我是彰化基督教医院杨元博医。
Dr. Chen Diyong from Tainan Cheng Kung University Hospital, cardiovascular surgeon.
So let's start our section. Because the room is preparing, so now we are starting from the lecture first. Now we have the Yang Yuanbo, Professor Yang Bo. He will tell us the lecture CO2 angiography in PLD. And this is a recorded lecture, so now please go ahead.
各位同学大家好，我是彰化基督教医院杨元博医师，今天为大家介绍二氧化碳在周边动脉的应用。在平常的血管摄影中，偶尔就会看到这样的影像。那这是打进去冠状动脉里面的空气。事实上，从1914年开始，就发现到空气是可以当作放射使用的显影剂。在同个年代，也发现到除了空气，二氧化碳也可以拿来当作显影剂使用。经过40年，才开始有人把二氧化碳用在人体的动脉与静脉上面。接着，因为 DSA 的发展以及 FDA 的 approve， 二氧化碳越来越多被使用在取代含碘的显影剂，尤其针对显影剂过敏或者是肾功能不好的病人，更是会使用二氧化碳的显影。二氧化碳的特色是什么？首先，它几乎没有过敏的反应，没有人会对二氧化碳过敏。接着是没有渗毒性，在使用上也没有最大剂量的限制。原因是因为它会经过肺部代谢掉，所以也不会有对肾脏造成太大的影响，也没有干毒性。那辐射量也是偏低的，本身也没有无色无味。换句话说呢，这二氧化碳对于人体来说是相容性可以达100%。它在它的物理特性上有哪些特别的地方？那大家晓得二氧化碳它其实是一种空气，一种气体。那对于血液的话呢，事实上是不会去混合的。但是这二氧化碳它会造成一个暂时性的 ischemia。第二个就是二氧化碳本身的浓稠度非常的低，跟显影剂来比，跟一般含碘的显影剂来比，它大概是含碘显影剂的400，就是粘稠性比较低的400倍。所以二氧化碳其实在血管上它很容易就流过去了。 第三点是二氧化碳，它跟氧气来比的话，它溶解性是高20倍，所以这些二氧化碳它很快的就可以溶解在我们的血液里面。最后一点就是二氧化碳它的排除，它事实上在我们人体里面就是透过肺循环的排除，所以对肾脏来说并不会造成太大的影响。那为什么要使用二氧化碳呢？当然主要就是针对对于含碘的显影剂所有过敏的。那第二个就是针对肾脏衰竭病人，糖尿病患者本身产生 AKI 的几率也比较高，所以也可以考虑使用在糖尿病的患者上。高血压也是一样。那病人如果他的creatinine偏高的话，大于 1.5 以上，这些病人也是可以考虑来使用二氧化碳。以缺乏小于60以及担心显影剂所造成生病变，都可以使用二氧化碳。哪些血管可以使用二氧化碳呢？那针对动脉的话，主要是在横膈膜以下的话是可以使用的。那在颈部以下的静脉都可以使用，包括大家常听到的 Messenger syndrome 或者是 AV shunt 这些其实都是可以的。再来就是我们要如何去使用二氧化碳，那最主要的是我们不要去使用人工的用手去打。那原因是因为我们有自动的方式，可以在机器里面把一半的 air 先排掉。那用整个像这个机器的设定是整个触控面板都是属于电子化的，就是并没有那些按键之类的。那他们调100%的 safe， 这是官网所写到的。那对于user来说，其实也是很 friendly 哈，因为它有不同的设定，设定好之后，其实再打就很方便了。那刚提到不要用手的原因，是因为我们用人工的手打的话呢，它的用力的程度会不太一样，可能前面大力，后面小力等等之类的，就造成这些影像的显影不会太好。但是如果是使用机器的话，它效果就会比较理想。那什么样的设备才可以使用二氧化碳的显影？那目前建议就是一定要有 DSA， 至少要 DSA。那 frame rate 的话要3张以上。那这两个情形，一般的 angio room 或者是导管室几乎都做得到。那接下来就是二氧化碳的一些软体或者是它的后置的建议哈。那这两个当然不一定要有，在我们这里也是尝试过，单纯使用 DSA 所看到的结果也是蛮不错的。那会不会有其他副作用呢？当然病人可能会有刺痛感，会有一些温热的感觉哈。那有的人会恶心，但是这些统统都是属于短时间的不舒服，对长期来说并没有太大的影响。那 critical issue 部分包括 air contamination 或者是 CO2 dose 以及 CO2 pressure， 其实只要透过机器的设定，几乎都不会出现太大的问题。就2024年的 Link 也有发表一个有在一个 section 里面特别去讨论二氧化碳，所以二氧化碳在目前的应用上应该是要非常广泛的才对哈。以上做简单的介绍，谢谢大家。
Okay, thank you, Dr. Yang's presentation. And our next lecturer will be Liang Huaiwen. He will tell us the story about choice of atherectomy device. So, please, Professor Liang.
Okay, thank you. I'm Dr. Liang, and I think it's a good chance to. Next 是哪一页？下一页是哪里？好，那我后面就会用中文讲。好，谢谢。那我想今天时间很宝贵，我们只有6分钟当暖场用了哈，所以我想我们就 overview 一下，把我们今天听说这2天有27个 case， 我想这真的是大家第一次参加这么疯狂的 PAD 嘉年华哈。那我想我今天就快速把这2天我们可能会用到 atherectomy 快速的带过哈。我们有机会，我想做钙化的医师都有机会用到 Hook One， 因为如果假设像这种 eccentric plug， 你用本论硬撑的话，那就是绝对撑不开，所以我们会需要这一种就是适合偏心型的 atherectomy 的 device。那我个人觉得啦，Hook One 它大概是很适合用在 calcium nodule。那事实上 ，Hook One 用在一些 non-stenting zone， 比如说 common femoral artery、popliteal artery 都有很好的 result。所以呢，我们说小的 Hook One， 像这个 case， 它其实就是有点 distal SFA 要进 P1 的地方，这边有一个 calcium nodule。那我想 Hook One 的小问题吗？就是它前面没有这个 debugging 的效果，所以它常常需要一个小气球撑。那撑完之后呢，我们就开始 Hook One。那切完之后，其实可以从这个 case 看，其实真正切 Hook One 也没有真的花那么多时间啦，大概多48分钟，可是你可以得到一个很好的 lesion result。所以我想这个 P1 的 calcium nodule 在用 Hook One 之后 DCB， 它有很好的 result。而要不要摆 protection device 呢？从这个 case 我们可以看到，一定要摆，因为如果不摆，这些东西都会掉下去。所以我想 Hook One 的使用就是第一个，因为它前面没有 debugging 的效果，所以它常常会需要一个 lesion prepare。而且它是一个手控式的，等于是 operator 要一边听声音，一边用触感去调整你 blade 的方向。那一定要用 distal protection。那另外一个我觉得很适合的情况就是都是这种 non-stenting zone， 然后 common femoral 的 calcium 然后就大概在这个位置。只是这个 case 我这么特别来讲呢，是因为我想做 debugging 还有一个重点，就是你要出 lumen wiring。这个 case 大家看，这么快的 slide 到底在看什么？我只是想告诉大家，这个 case anti-grade 我用了以上1排 wire， 花了71分钟 anti-grade 都过不去，硬的软的都试过，因为它就是会怎么讲，没有办法从钙化中间穿进去，那从边边也走不过去。可是呢，如果在这个时候你用 retrograde， 其实胖这个也不难，因为它都有钙化。其实可以看到 Gladius 18 retrograde 很快速就上去了，而且它跟 anti-grade 的路是不一样的，9分钟过9分钟过。所以我想有时候在钙化的 lesion， 我们可以用 retrograde 来帮忙。那一样它是 Hook One， 所以我们要先用一个小 balloon lesion prepare， 然后摆放 spider， 黄色的是 spider。绿色的是我的 distal puncture 的地方，那记得 spider 的位置要跟 hook 至少接近10公分以上。好，那我想这个 calcium 呢，就其实走 wiring 的时间远远超过 debugging 的时间，所以 debugging 大家真的不用嫌它麻烦。但是可以看到这个 case 一样有放 distal protection device， 所以它有些 debris 发生。那讲完 hook one 一定要讲到今天的主角啊，前面第一台 section 已经有2个 case 用到这个 jet string， 那 jet string 的差别跟Hook One最大的差别是，它前方呢可以做 debugging， 它前方就可以做 debugging， 所以它有时候不一定需要一个小气球 lesion prepare。好，那而且呢，我想它是而且我们都知道它有我们常用的，这是我们常用的尺寸然后你就是 blade down 磨，然后再吸，然后再 blade up 磨再吸。那可以看到这个是今年吴旭平医师在我们义大 demo 时的速度，我觉得这是一个可以给大家看，就是说我磨真的要慢慢的磨不能急每分钟1 mini 的速度。那磨的时候呢，在 jet string 呢，我们知道日本的做法跟我们好像不太一样我们大概还是要使用 distal protection device 才不会担心那些 debris 掉下去所以像我觉得什么 case 适合jet string 呢，就是像这种 concentric 的钙化，而且它是比较长。如果你用 hook one 慢慢的刮，你可能要刮很久的时间。那我想这个 case 可以看到刮完，然后气球撑完再 DCB， 那要不要用 distal protection 呢？是要的虽然这些 debris 看起来没有像 hook one 那么大，可是其实如果它真的掉下去，还是有可能造成 distal no reflow。看有用网子接就是不一样那什么时候要想到 jet string 呢？我跟大家分享一个我最近的 case。今年5月我做了一个 case， 我想我们再看一次这个病人的血管，超级钙化，超级钙化。那时候其实 distal 的地方我们是用 Gladius 18很快就过去，然后就死命的用气球撑，怎么撑都撑不开。可是后来还是用暴力的方式把它撑开了，然后也快速涂了 DCB。这是今年5月23的时候。我想乍看之下这 case 大家还蛮满意嘛But the same patient， 1 month later， 今天讲了唯一的英文，就同一个病人，可是呢，1个月之后呢，大家可以看到 the same patient 1 month later 又在这个地方塞住了。这我想这令人很不可思议啊！你刚不是都打通了 DCB 了吗？所以这个 case 告诉我们，严重的钙化，你如果没有做好 debugging， 就是这样。而且大家还记得吗？上次这个地方是用 Gladius 18过的，这一次 Harbor 14也不行 ，Astato 一直到 Astato 30才过，所以代表它经过怎么讲？用力的撑开，然后再涂药，可能有造成这边产生 fibrotic 的 lesion 所以我想 jet string 我们就拿出来，它就是用在这个时候，我甚至觉得第一次就应该使用。那 jet string 完之后呢，我们还有搭配 cutting 再涂 ranger， 这是后来的 finding。那现在已经11月了，然后怎么讲 ？5 months later the patient didn't come back， 代表他的伤口愈合应该不错。但我们还有什么 atherectomy device 呢？有时候我们会把 coronary 的 rota 拿来周边用。我们知道 rota 有这些 size 那甚至 coronary 我想大家可能都用过 2.25 的 rota 在很大的 RCA， 可是我不知道大家有没有用 2.5 理论上 2.5 不应该出现在周边的 rota。什么时候我们会想到周边的 rota 呢？像这个 case another case， 今年3月的时候，它是在PUP 跟 tibial 有 near total， 那 Gladius 18也是很快的过去。那我们可以看到，对于这种钙化，如果你只用气球撑，乍看下好像都不错，甚至这个 case 我也涂了 DCB 哦，可是一样This is another patient, but the same patient 1 month later， 一样又发生一样的事情。DCB 涂完之后，又在这个地方塞住，而且这次一样，也是 Gladius 18过不去，我们一样用比较硬的 wire 过去。那大家可能会说，你这个 case 为什么不要 jet string？因为 jet string 我想对这个3.0、2.5的血管来讲 too big， 所以我们选择用2.5的 burr 啦。那因为时间的关系，我们就快速的过。那我只是要提醒大家，周边的。拿 corner 的2.5 burr 磨这边，我们大概不怕这个 burr 会怎么样 entrapment， 可是要小心哦。你磨 P3 到 ATA， 因为这边有一个很大的90度的转弯，你可能不会 entrapment， 可是你有可能会 burr perforation， 所以可能磨这个转弯的地方还是要慢一点点。那总而言之，我们用 rota， 我想这也是一个 debugging 的方式。磨完之后，再用气球撑。再用气球撑，那撑完之后呢，再涂 Rangel， 至少这个 case 6 months later，the patient didn't came back， 他也没有再回来。那今天最后的一个 debugking 的演讲就是说，大家可能会说你前面3个都要花钱有没有便宜好用的方式？我觉得 needle crackle 也是一个好用的方式，然后它就是我们刚刚讲的所有的 debugking 方式它都是磨什么呢？它是磨 superficial 的钙化。可是 needle crackle 它不是从里面磨，它是从外面去破坏这个钙化的结构，所以它其实是一个 translumen 的 lesion modification， 便宜又好用，唯一的 cost 就是我们的手啦所以大家可以看到这是一个今年的一个我们做的一个 distal SFA 到 P1 的 heavy calcification， 这个真的很硬硬到我在走 wire 的时候 ，wire 甚至 tip 是 broken 在里面的那 NT 不行，我们就 retro 那 retro 看起来很近，可是呢，看起来也在出入门面，可是 wire 就过不去。所以我第一次 needle crackle 是 for 什么 ？for retrograde wire cross the lesion。那 needle crackle 完之后 ，retrograde wire 就真的 cross the lesion 了。那后来就完成 externalization， 可这只是第一步，完成 wiring。我的任何 device 都过不去，CSI 也过不去 ，coronary balloon 也过不去，所以我那个时候又再做了一次 needle crackle， 让 coronary 的 balloon 可以过去。大家可以看到一个 1.0 的 balloon 就有点往前进。可是周边的 balloon 2.0、40的 balloon 都过不去 ，even I use bad foam technique 也过不去，所以就在 needle crackle。其实我想强调是这种 needle crackle 的方式，它其实也是一种 lesion modification。大家可以看到这个 balloon 就下来了，那 balloon 下来之后，我们就撑。那这个 case，如果假设没钱，那你就是用气球的撑的方式。所以气球撑完之后，其实可以看到 cutting 完之后，这是病人的 final。那如果有钱的话，我想用 jet string 会是一个更合适的方法。那今天最后一个 case，那如果你坚持呢，即便听完我们 atherectomy 的 choice， 可是你还是说坚持 I don't use any atherectomy device， 那你可能就会发生我后面这个 case 的悲剧很像的 case， wiring 的过程我就跳过，也是 NT 不行就换 retro， 它是从 P3 过来，那 retro 就是 retro， 那 retro 也是透过 needle crackle 的方式，跟刚刚那个 case 很像，但他们其实是不同的病人他是用 reverse cut 的方式过去。好，那我这个 case 是给大家示范，如果在这么硬的钙化，你坚持不用 atherectomy， 你就是用气球撑好撑慢，那我们来看会发生什么事情这个就是手术的过程，这是 externalization 的过程。这也是用 bad foam 的方式把这个把这个气球先带过去才能撑嘛。那我们看一下撑完的样子。如果坚持不用 atherectomy 就是这样子，该开的地方不开，不该开的地方甚至还有一点点，大家应该看到它密的 SFA 其实有一些 dissection 跟 perforation， 所以这个 case 其实理论上，我想外科医师在现场都觉得这应该是要找外科开 bypass 如果你坚持不用 atherectomy device 的话，所以最后我们只好变通，做成一个 pave and crack， 因为那个 extravasation 嘛，就放了一个 wire band， 再用力的把它打爆打开，我想这是一个应急的做法。所以今天的最后我想快速的 summary 一下。所以我这个部分是讲 atherectomy 的 choice 可是我们都知道钙化的血管，我想这2天都会遇到，它都是让手术很困难，而且手术的预后不好。而我们今天会希望说可以用一些 atherectomy device 跟 DCB 来到好的效果。那怎么做选择呢？我想 Hook One 就是选择 eccentric plug，jet string 呢就选择 concentric plug。但记得这2种方式都一定要摆 distal protection device。那你当然也可以选择 rota， 那 rota 我觉得比较适合是比较小的 below the knee 的血管。那记得你要选择这3种方式，你都要出入那个 wiring。那如果因为 cost 的关系，这3种方式都不选，那至少我们就学会 needle crackle 的方式，它也是一个便宜有效 lesion modification 的方法。好，谢谢大家，谢谢。
Thank you, Professor Dr. Liang. So now we go into the Zhangji room, room 1. The case number is 11. Hello. The operator is Dr. Yang Zhongyuan and Yang Bingzhong. Hello, can you hear us?
Yes, I'm Dr. Yang. I'm come from Taichung Zhongshan Medical University Hospital. And today our case is a restenotic lesion. This patient received left superficial femoral artery PTA last July.
Do
Can
you
we
have
see
any
the
case?
angio first? This first angio, this one, we can see the left SFA total occlusion.
Yes.
Yes, he had some choroidal circulation, but the left SA near total, chronic total occlusion, CTO. The distal left SA have a standing DES, stent deployed last July. The instant total occlusion. And the proximal to middle femoral also total occlusion. Proximal to middle, this segment had PTA, DEB before, but the outcome is not good. So this vessel left as a severe restenosis. So our strategy today, we need your opinion.
So anyone has a comment for this case?
I was.
Okay. Dr. Yang, I'm Dr. Lee.
Yeah.
Yeah. I'm not very sure that the previous angel is the CTO similar.
No. Last year, his severe stenosis, not CTO.
Okay. Because at the very proximal part of the previous stent, the angulation of the vessel is very strange. The stent is outside the stent, and maybe previous wiring is not very correctly in the true lumen.
False, maybe?
Yes. Could you show the initial angel? The proximal stent.
Last year.
Yes.
Last year. Do we? Recall. 那个可以开始了吗？按。现在有开始录了吗？啊，我往回。很暗。这里 instant。我什么都没，就看到 stand 的影子。这 flow 高一点。We prepared the angio last year. So today we will be wiring first, then small balloon dilatation, further IVUS guide.
But the IVUS, we cannot see anything now.
Yes, we prepare now. The IVUS quality is not good.
And could you tell us that the patient, the symptom is very acute or subacute or chronic?
Subacute.
Subacute.
Yes, the ABI index progressed down, and he feel that claudication progressed for several months. Okay. And we had a CTA 2 months ago, and the CTA showed the left SFA total occlusion, the same as the angio today.
And today you just do the anti-gray approach and
yes, we right side femoral puncture and cross over to left side.
And
we'll be, yes.
So the wire is the soft wire and quickly close the lesion, right?
Yes, Gladius 01A. It could easily pass through the CTO lesion, pass through the in-stent lesion, and to the distal popliteal. Then we use 3120 balloon to pre-dilate, then IVUS guide.
Okay.
The balloon, the 3 balloon is also easy to pass this CTO lesion and pre-dilate up to 10 bar. After this, we check IVUS. This is now what we do.
非常恭喜，我是台北马偕孙医师哈。那我直接讲中文，因为我知道你们正在努力中哈。那如果外耳那么容易过的话哈，会不会担心里面？而且从它的症状看起来 recurrent 的速度算快，会不会担心里面是一些 thrombus？ 那你们会考虑做一些 distal 的 protection 吗？尤其是这个 stent 里面的，或是说上面那么容易过的话，可能是一些不是很旧的一些血块。
可能是 yes, maybe acute on chronic.
So will you press some, do some procedure
this
to?
protection is a good suggestion. Yes, but not every case we will do that.
For sure.
So we check IVUS. If many thrombus in the IVUS view,
yes.
we will protect.
Yes.
But if hard plaque, so maybe not necessary.
Yes, very wise step. Okay.
Hello, Dr. Yang. My Reza. I want still waiting about your IVUS after cross the lesion. What's your strategy about after use the patient subintimal or intraluminal, and what's your strategy if you found the IVUS for this patient?
刚刚前一台是好的。
So maybe the IVUS is some problem, so we change to the room 2, and we will come back later. So let's change to room 2.
先换到我们的画面。Good morning, Professor Gan.
Yeah.
Can you hear me?
Yes, we hear you. This operator is Professor Dr. Zhang Jingtang and Xie Youquan. So, Dr. Zhang, can you brief this case?
OK， 那开是不是有一个 slide 会秀？对，会场那边先秀 slide。
The next case is a 71-year-old man whose past medical history included type 2 diabetes, hypertension, and hyperlipidemia. He had also been on warfarin for heart failure with LV thrombus. This time he came in with left leg claudication. His ABI were 0.84 for the right leg and 0.81 for the left. CTA found lesions in bilateral SFAs, and our target today is the left SFA.
Okay, and this is the SFA lesion, and in the computer tomography, there seemed to be a nearly total lesion. And in this case, it's not so difficult, so we use the CO2 angiography for this case. 秀一下那个伊列克的像。So this is the CO2 angiography in the iliac artery. We see not very severe stenosis. So we cross over the iliac artery. 下一张。The common femoral artery and the proximal portion of the femoral artery, the no stenosis. And the next one. So for the better image quality, we selected the catheter to the middle SFA, and we can see the actually is nearly total lesion. And then 下一张。Sometimes we worry about the CO2 angiography cannot cross the nearly total lesion, but in this case, I think the popliteal artery is patent. 好，再下一张。We did not open the lesion now, so the angiography is not so clear. 对，好，那再下。So we use the telumo wire, the telumo telumo wire and the stiff wire, and 下一张。是stop fluoro 的那一张。
Dr. Zhang, I'm Dr. Lee. When you need to use the CO2 angiography for the patient, would you combine the IVUS for this kind of the procedure?
Actually, I plan to use the IVUS now, so this is I will change to the 0.018 wire, the connect wire. And I will use the 现在可以用 IVUS 了，对，那 IVUS 卡西特先上来，对。
So Dr. Zhang, maybe we can come back later and we go back to the room 1 first.
Okay, thank you.
Thank you. So we go back to the room 1 and the IVUS. Can you tell us the IVUS?
Yes. Room 1, IVUS, please. Can you see that? Yes.
Dr. Yang, is there any IVUS commentator for us?
Yes, please. We need IVUS man.
Is the room have or anyone suggest
Dr. Yang, I think this, you have success to cross the two lumen, and the lesion is very tight, fibro, plaque, sometimes is thrombus in its proximal part. I think the important maybe the bulking, the first is the bulking is more slow because to prevent about the target MLA. Maybe you only in DCB, I think.
DCB only. And IVUS imaging, do you have suggest?
Could you show us the segment of the stent? What about the
Segment of stent, IVUS segment. Here is in-stent IVUS.
We cannot see very clearly the stance chart.
Yeah, we will do the IVUS again to the popliteal artery. The many plaque and restenosis was noted. Not so much thrombus. So maybe distal protection is not necessary. Now we'll do IVUS again to popliteal.
Sorry, Dr. Yang, we have to leave briefly, and we will go to the Zhongguo University Hospital for the previous case on the section 1. Room 2.
慢慢拉，看起来在 P2 的地方都还好。
No, the Zhongguo room 2. Hello, scalpel. Hello. Already left? Oh, okay. Sorry, so we go back to the Zhangji room 1. Okay, so we go back.
It's a middle to proximal. Okay, here is common femoral artery. Good.
Any comment from our panelists for this case?
I want to comment about
sure.
this IVUS. The patient not too so much about the calcify, but thrombus and fibroplaque. I think the selection device for atherectomy is important.
Okay.
Maybe like Rotarix, I think we can use.
Dr. Yang?
Yeah?
Can you hear us?
Yes.
Yes, okay. So we should show more.
So after IVUS, what's our strategy? If no distal protection, I suggest 5 balloon POBA, balloon angioplasty. Balloon 120. 510.
So in this time, we go back to the Zhongguo room 2. Skypon will tell us the result of his last case. So we go back to the Zhongguo room 2. Hello, Skypon. Can you hear us? This guy.
Okay.
There's no sound.
Can you hear me?
Yeah, sure. I'm Dr. Gan from Thai. Hello.
Hello. 还是你用我的。Hello.
Hello, Sky.
Yeah. Hi.
Hi, I'm Gan.
Yeah, I'm sorry we finished late and then we have the case just done, the MTS stenting. And can I show the last final angio? We just promised the last session to show you the completion angio after ballooning. I think it's acceptable with such a long lesions. Luckily that we decide to go from popliteal vein instead of the initial plan. We just planned to puncture the femoral vein, but we found that the femoral vein is also diseased. So we just and also with tough long occlusions, we just managed to cross it and put in a stent. Can you see the final angio now? Sorry? Not this one, the next one, the final one, please. Yes, this one. So can you see?
Yes.
Yeah, that's all. We put in a 16 millimeter stent from the proximal and then followed by 12, and then 12 millimeter and 10 millimeter. But we only balloon up to 12 millimeter. I think that the size is adequate. But I'd love to apologize because the IFRS is not working. We just do the sizing based on the CT scan on the contralateral size before the operations. That's it.
Okay. Any comment?
In previous section, we see the angiography and the flow is not good. Could you tell us what's the reason of the inadequate flow back?
Yeah, on the initial angiogram, the problem is likely over the common femoral. The stent is not open very optimal. There's some kinking, I think. And after further ballooning, because initially we didn't balloon very aggressive because the patient felt quite painful. And then, but after several angiogram assessed, and then we found that the flow creates at the level of the common femoral arteries. So that's why we keep the further balloon, more aggressive balloon dilatations to make the stent open up better. And then afterwards, this final angiogram, I think this achieved better results. I think one of the important points in doing wing stent is the use of IFRS, not just to assess the lesions, but also assess the stent expansion. But unfortunately, we don't have the chance to demonstrate to assess the stent expansion on this case.
Okay, thank you.
Okay, thank you, Sky.
Thank you very much.
Thank
okay,
you.
See you.
Congratulations,
Thank you very much.
you're done. So we go back to the Zhangji room 2.
Hello?
Hello.
Can you hear me?
Dr.
Hello,
Zhang.
hello. We just prepared the IVAS and please show the IVAS image. We use the Boston IVAS, peripheral IVAS. IVAS play 一下。没关系，我来操作。 下哦，前一组啊，用 Volcano， 所以前一组要怎么修？啊？不，我机器要先叫出来。前面 play 的那一组，刚拉的那一组，刚刚拉的。这个吗？哪一个？好。We pull back the IVAS from the popliteal artery, and in the P2 and P3, the no stenosis. The vessel diameter is about 6 to 7. The distal femoral artery, more some atherosclerosis and calcification. A nearly total stenosis at the distal femoral artery. So the wire is across the lesion and all in the true lumen, so we plan to do the balloon angioplasty.
So any comment from our panelists?
Hello, I'm Dr. Tsai from Chang'an, and congratulations. It's a very nice image for the case. And so I will show is in the true lumen check-in, and with maybe this is a manual pullback, so maybe it's a short segment of the fibrotic stenosis. So maybe DCB will be adequate for this patient's treatment. Thank you.
Thank you.
Oh. No further question. Any suggestion? Okay, Dr. Chen.
Hello, it's Dr. Chen from Tainan Cheng-Kung University. And since we know that the underlying pathophysiology of the restenosis after bare balloon angioplasty and in-stent restenosis are extremely different, and as for the in-stent restenosis, the lesion consists more smooth muscle ingrowth compared to the bare balloon angioplasty restenosis. So besides a balloon POBA or DCB alone, would you think it's useful, or do you recommend to apply any atherectomy or debulking devices for this in-stent restenosis lesion? Thank you.
This is not an in-stent restenosis lesion.
This is a case, room 2. This is
room 2.
It's just short segment stenosis. Total.
它旁边那个是前齿。
I'm sorry.
Oh.
Okay. So, Dr. Zhang, please, maybe you persist your procedure. Now we go back to the room 1.
Okay, thank you.
Hello, Dr. Yang. What's your progress? No, go back.
Yes. Okay, room 1. Now we use the 5 balloon to POBA. After balloon dilatation, this angio next. Final angio. This one. We can see the SA residual severe stenosis. We have some flow, anti-grade. And the distal in-stent also had some stenosis. So we will repeat balloon angioplasty and in-stent another DEB dilatation. And proximal to middle SA will you select a DB or DS?
Okay. So, Dr. Chen, you can ask your question.
Did you hear my question for the wrong
No,
operator? And my question is the same for you as for this instant restenosis lesion. Do you think it's useful to apply some debarking or ulcerectomy device for the instant restenosis lesion since the lesion consists more smooth muscle ingrowth?
Yes, that's a good choice. We use balloon predilation and see the angio again. Any debulking or DB will be considered. And proximal to middle femoral artery, will you DB or another long-standing?
Anyone has any comment for this case?
No.
Do you have the previous angiogram last year? Because this seems combine the disease progression and the instant restenosis.
Okay. Last year, original angio.
Yeah. It is related to the mechanism of the instant restenosis and the disease progression.
Yeah. 去年的。
Yeah.
对。哦，高了点。啊。去年 last year, last July. We.
So can you show the angel?
Okay, we prepare the last year angel. 去年的。
Okay, this is the previous angel.
What's the image? Where? Oh, here. Can you see that? That's
yes,
July.
we see that,
Next.
This is the final angel of the previous PTA?
Yes, the original femoral angel. The first one. Next张。下一张。OK， 下一张。Last year, last July, also CTO. This is profunda. Next. Next. This is distal femoral. So this lesion proximal to distal femoral or restenosis, even severe occluded, total occluded.
Sure.
So we can see the instant outcome. Restenosis is not good. Even the DEB segment, proximal to middle, or restenosis, severe reoccluded. So what's your plan?
According to the today's angiography, after balloon angioplasty, we can see a very long dissection from very proximal SFA to the near the stent area. So I think the DCV is not good for this kind of the situation. Maybe the DES is better for the vessel patency in the long run.
Stenting from middle to proximal.
Yes.
Or Austin.
Yes.
Cross the Austin.
Yes, because very long dissection after the angioplasty.
Yeah. Maybe we need 2 long DS.
I think the SFA inflow is also very important. In last year, the SFA orifice is narrowing. So do you think this time standing is cover the SFA orifice?
Yes. Some people think we maybe preserve the Austin. But some people say that profound maybe crossover. If the profound Austin is good, crossover will be possible. Okay.
So Dr. Yang, you proceed your procedure. We go back to the room 2. Now, room 2. Dr. Zhang, you will give us the final result.
Okay, and after the balloon angioplasty and use the 6.0 millimeter balloon, and 秀一下那个balloon在撑的，balloon在撑，再往前，再往前，我balloon在打开的那个，好。Actually, the lesion is between the 11 millimeter to the 3 centimeter, 11 centimeter to 3 centimeter. So during we use about 6 bar and slowly inflate the balloon. 下一张。So the lesion is fully expanded after the balloon angioplasty, and we balloon inflate for 2 minutes. And 下一张。So we use the CO2 angiography, and the Bravo is good, and no significant dissection. For the comparison, 下一张。We do the contrast angiography again. 前一张。这张。The lesion is fully expanded and no dissection, no flow limit. So I think maybe in this case, DCB is a good choice.
Okay, congratulations. Any comments from the panelists?
Should I do the IVA scan for the post-dilate, for the lesion after the balloon angioplasty?
Dr. Zhang Jintang. Hello. Professor Lee is Li Mingli is asking you for the CO2 angiography is easy to see the dissection.
I think it's difficult to see the dissection, so we do the contrast angiography again, but no dissection in this region. But and I think the image quality of the CO2 angiography is very good in this case.
Sure. So okay, congratulations for your case. So we go back to the room 1. Professor Yang, any progress? Can you tell us?
Now we will give him a long stand, 6 and 150. Here we go. Over depth. Now stand deploy.
What stand are you using?
Rencho. This is Rencho. Oh, Illuvia. Illuvia. Stand deploy slowly. Now, this is the first standing. Now we will use another one. Maybe 6 and 120. Shorter. After stand deploy, we will balloon post dilate again. Then we will be the IVUS check. And the Austin, femoral Austin will be crossover. The profound Austin is good, is healthy, so it may be not necessary to protect wiring to profound up.
Okay.
Now give me the second stand. 我看一下下面。上面，诊断 reference， 下面，好 ，6 and 100， 20。Okay, 120, 6120，哎，所以要有比例尺 ，DS， 这150嘛。所以要有比例尺比较好的。The patient is restenosis within a very short time. PTA last July. So now, almost restenosis within 1 year. So the DS strategy, 2 long DS stent deployed today, will give him a good outcome. I don't know.
Dr. Yang, because this angulation is not good for the to see the common femoral artery bifurcation site. So
lateral view.
Yeah, maybe you can choose another lateral view to see better for the stent deployment.
Thank you. 尾巴拉住。
And the stent length, you choose the 120?
Yeah.
It seems too long. If you don't want to cover you don't want to cover the deep femoral artery.
Or 100. This lateral view is not well defined Austin. The previous frontal view, I think it's better. Frontal, 到这。等一下，我再找。I will check angio again. $100.
From this view, we can see the ostium of the profonda seems to be moderate diseased. Do you want to cross over?
Yes. Or wire protection. Should we? Twist it. Okay, we'll go another wire to profonda. Or should we give him a small balloon to profonda? Not for dilate, but protect the ostium or profonda. This is due for not gel for ostium or profound.
Dr. Yang, I'm
Another
Dr.
wire.
Tsai from Chang'an.
Gracias.
After the standing for middle part of SFA, the proximal SFA is not really so clear. And of course, if you want to stand in to the proximal part and even cross over the profonda, the protection may be required. But I'm curious, should we do IVUS again or to do some image for a clear view of the proximal part of SFA? Should we do to place another stent or just do the DCP only?
Okay. Yeah. I think the IVUS will be done after second standing. But you have a good suggestion. We can see the IVUS now and decide the next step.
I agree with the IVUS image again because there is some moderate stenosis above the bifurcation. So if you do the stenting near the bifurcation, maybe the
crossover.
I don't favor crossover the bifurcation.
Yeah.
If
even after wire protection.
Yeah, I'm Dr. Sun, and I cannot agree anymore, because I think maybe after IVUS you just need some DCB to simplify your procedure and reduce the risk of some complication around the bifurcation.
Okay.
Yeah, maybe the very proximal SFA orifice is okay, and just do the DCB and very short DS stent. Yeah.
The Wang Daro from Shuanghe Hospital. According to the contrast density of the SFA ostium, there are another possibility is I think maybe the plasma, the wire in the SFA ostium are in the subintimal space because the contrast density in the vessel two side, not in the central. In this condition, we should consider about the wire in the subintimal because, however, because his outflow is very good, so it is very difficult to tell light. So IVAS is very important in this area.
Give you the IVAS. This is IVAS again from the stem to proximal femoral and ostium. Run. IVAS. 没，播放刚刚那一张。好，补。This is proximal femoral.
I think maybe the wire is the true false true.
Proximal.
Maybe this is due to previous procedure, not this time. Yeah, this is the true. Maybe yes, this side. Maybe the 9 to 12 o'clock. This is the true lumen, previous true lumen.
Yeah. We use a Gladius soft wire to pass through it very quickly. Now we create a big false lumen. So the proximal SVA need a standing, right? But preserve the ostium. DB only.
Yes.
Okay.
Okay, maybe you persist your procedure. So now we have a lecture from Kazuhiro Sato. He will tell us the lecture and the current trends in AVSS in Japan, balloon catheter treatment strategy. So, Sato Sensei, please.
Okay, let me start. So when we talk about the characteristics of the balloon, well, we usually talk about like dilatation efficiency and deliverability. And we have two types of the balloon, which is one is ultra high pressure balloons. Well, its dilatation efficiency is better than the others, but I think the deliverability is worse than the others. And this is well, the situation of condition of Japan. We only can use one balloon for one intervention. So when we choose ultra high pressure balloons, well, so we can't dilate the regions near anastomosis or regions at anastomosis or proximal artery. So in that case, we will choose the like low and high pressure balloons, which is deliverability is better. But then we cannot maybe dilate the stenosis completely. So that is a trouble in Japan. So the good trackability ultra high pressure balloon is ideal in Japan. So I want to promote Yoroi from the Japanese company, Kaneka Medics. So it is well, ultra high pressure, ultra high pressure balloon, and And it also has a good trackability as the movie shows. So it is a, well, ultra high pressure balloon which can dilate the stenosis near anastomosis. And this movie is a real case. Left side is a balloon conquest. Guide wire is already into the proximal artery, but it doesn't go through the proximal artery because the shaft is very stiff. The right side is a uroi. It smoothly advance through the anastomosis. So it has a better trackability than conquest. So uroi has important characteristics. One is a good dilating efficiency, and second is good deliverability. But uroi has other important characteristics. It prevents balloon slip phenomenon and it prevents region slip phenomenon. I will explain about these two characteristics. The structure of uroi is very specific. It's many strings are on the surface of the balloon catheter, like this. The theory, I think you know, all you know the balloon slip phenomena, but this region slip phenomenon is a new word. And Dr. Yasuki Motomiya found this new phenomenon. I show you the balloon slip phenomena by experiment. Here the balloon slips when pressurizing, but uroi doesn't slip like this. So the uroi has shows already that many strings on the surface of the balloon, and it prevents a balloon slip phenomenon like this. And this is a real case. I'm using a Mustang this time, and the case has a stenosis near the anastomosis, but it slips like this. So the stenosis didn't dilate it well. And now this time I use uroi for the same case. When pressurizing uroi, it's different from the Mustang. It doesn't slip. So after dilating by uroi, the stenosis completely dilated like this, and the function of the IVF improved. This is an explanation of the lesion slip phenomenon. Well, for the cases of severe intimal thickening with stenosis, during conventional balloon dilatation, the stiff stenotic area bends inward, resembling an avalanche effect. Normal blood vessels and the stenotic vessels are pulled toward the stiff stenotic region, resulting in further vessel distortion. The stenotic area becomes even tighter, requiring significantly higher pressure to achieve complete dilatation. Balloons that cannot exceed the necessary pressure to fully dilate the stenotic region may exhibit a dog bone shape, indicating incomplete region expansion. I show you for the real case. This time also I'm using the Mustang, and the stenosis is very severe and tight, and you see the tissue like surround the stenosis gathers to the center of the stenosis like this. Well, I think this phenomena is difficult to find by using fluoroscopy, but in Japan, many doctors doing the intervention by using echo like this. So we can find like this phenomenon very well. So this time, for the same case, I use uroi after the Mustang. You can see this flat shape. So this means the tissue doesn't gather to the center of the stenosis. So the stenosis didn't get harder and tighter, so I could dilate the stenosis completely. This one is a lesion slip phenomenon by fluoroscopy guided intervention. I think many doctors see like this dog bone shape. And in this case, we can't recognize the region slip phenomena by fluoroscopy. And by pressurizing to the high pressure, then the stenosis will be dilated completely. So even if lesion slips occurs, the high pressure will make stenosis completely. But lesion slip phenomena is a bad thing. It is a high risk of a blood injury. And this movie shows risk of a blood injury. This time also the region slips occurs, and high pressure attacks the normal blood cell, a blood vessel here. And after dilating stenosis, it also couldn't be dilated completely. Then the blood burst perforation occurs. So this means that lesion slip phenomena is a high risk of blood injury. So we have to prevent the lesion slip phenomena always. So I want to promote the Japanese balloon Yoroi. It has all characteristics, good dilating efficiency and good deliverability. And it's also, I showed already, prevent the balloon slip phenomena and prevent the region slip phenomena well. So thank you for listening.
Okay, thank you, Dr. Sato. So let's go back to the Zhangji room 2. Professor Zhang. Professor Zhang, you will tell us your final result.
来秀一下那个 DCB. I use DCB, Lutonics. 6 millimeter and 300 millimeter. 再前一张，非常的长哦，对。
So how's the length you chose for this patient? The size and the length.
After we do the balloon angioplasty and a small dissection is in the femoral artery, but it's not 4 millimeters, so we use the DCB. And after the DCB, 再往下看 ，DCB 再往下，对，好，这一张。We can see the CO2 angiography, the lesion is fully expansion and the blood flow is okay for this patient and the dissection is not significant now. 再下一张。We do the CO2 angiography, but seem to be a residual lesion. But we do 再下一张，再下一张就好，这张seem to be a residual stenosis, but we do the contrast angiography. 再下一张。Actually, the lesion is fully expanded and the blood flow is okay for this patient. So this is the final result.
Okay, thank you. Congratulations. And any question from our panelists? Yes.
How about the renal function of this patient? Do you prefer the CO2 angiogram rather than the contrast angiogram all the way?
Actually, this patient, the renal function is normal of this patient. So, but this is a simple lesion, so I try to demo the CO2 angiography in this patient and compare to the contrast angiography image.
Dr. Zhang, do you consider use the CO2 angiography in the venous procedure because the CO2 will direct enter the lung? Will you consider to use lower dose CO2 contrast in the venous intervention, or you don't think this is a big problem? So this is my wondering, because I know when we use in the arterial, the CO2 will enter the venous system will slower. However, if we direct inject the CO2 in the venous system, will there have any dangerous, or you have the limitation?
Thanks for your question, and I think I have no experience in the CO2 angiography in the vein, but I think it's difficult because the venous flow is more slower, and the volume is bigger. So I think in most of the case, the CO2 angiography is maybe the image quality is not as good as in the artery.
I'm Dr. Sun from Marquette Memorial Hospital. I have some experience about the CO2 contrast in the venous case. And when I did the CO2 contrast in patient with venous intervention, I will use the Trendelenburg position. And because according to the previous study, if the volume of air is over 15 milliliter, that will jeopardize the hemodynamics. So I always use IVAS combined with CO2 contrast to do the intervention in venous cases, that to reduce the risk of the pulmonary embolism and air embolism. Besides, I will do if I want to do it under the CO2 contrast, I always do the heart echo to prevent the paradoxical embolism, to check is there any intracardiac shunt.
For CO2 contrast, I'm usually in the patient the high creatinine in CKD stage 4 or 3 because the selection case. And for below the knee, CO2 contrast is very difficult to measure about diameter and anything else flow. Also, we must almost check, recheck again with the IFUS. The important is with the IFUS because IFUS is many advantage than only CO2 contrast.
Actually, for the CO2 problem, in the scalene therapy we use in the varicose vein, now has some physician, they emphasize that we should check the cardiac echo because sometimes we inject the air bubble into the vein, it will go down to the heart. It also is a big issue now. So, of course, we don't need to check there is a PFO or not, but it's for the venous to large volume injected is some worried the issue over there. So congratulations for Professor Zhang. So nice case, and we will go back to the room 1. Thank you. So Dr. Yang, you have final.
Now we have the second stent deployed.
Yes.
And now this is DEB for Austin. This one. After this DEB, we will check angio. No second wiring to profunda because we choose not to cross over the ostium. So we use this DB to cover the ostium, right?
Can you show the angel again?
Yeah, now is DB pop up for 20 seconds. The mini DB is 150, not so short. So we use a long DB. We have another choice. 50 seconds. Tiếp. Now we pour out the balloon and angel inject again. Okay.往下。Now we can see the flow is relatively slow. But the branch, profound and other branch also slow flow. So I think maybe low cardiac output. He didn't have the cardiac exam before. No ejection fraction data.
Okay.
But the flow is, the SA flow is similar to profound.
Sure.
And the ostium of profound is the same, preserved. What do you think?
Okay. Okay, nice job. So congratulations for your case. And we will go back to the room 2, and they has they will show us the.
Thank you.
要不要补一点 logo？ 我怕它会痛掉。
He will show us how to close the vein.
口有外有吗？口有外有。
close the
等一下
vessel.
把 focus 放在这边。
Hello, we go back to here.
点35的外在这里。口有外，口有我给我口有外。
Can you explain us what you are doing?
Okay, because we finished the procedure, so we want to close the device. Use the closure device to make the hemostasis. And the device we want to use the star cross. I think most operator was familiar to the ProGlide. And I want to demonstrate the usage of the star cross. 叙事。看一下，那个他原本推掉那个叙事，不是那个 star cross 的叙事，对 star cross。开了吗？可以放这边。 The star cross is different from the ProGlide, and we have to use the skin prepare. Stop it. 刀片，哎，刀片要 cutting 一下。不用。We use the knife to cut a little wound for skin surface, and we use the coil wire to change the star-cross sheath. This is star-cross device, and there are 4 numbers on this device: 1, 2, 3, and 4. The first step, you have to insert the tip of the star-cross, and you can hear a click, and then you press the number 2 button. And pull back. And then use the 3 advance into the skin. And press the button 4. Okay, it's finished.
Okay. Any pointer we should notice?
Sorry?
Any point that you will tell us to be noticed in this procedure?
Okay. You can see this one. You can see here. I didn't press the puncture site. And the wound is very clear. No hematoma.
Okay.
Because the star-cross always just suture the out layer of the vessel. I think it's a good device.
Good job.
Usually when we use these kinds of the vascular closure device, we need to do the subacute dilatation and the skin a little pre-dilatation to let your closure device can to easily insert to the subacute area. And the other point is that the vessels, the sheath size should be below, I think it's the A8. So if it's the large sheath, you cannot use this kind of the vascular closure device.
Okay, so thank you for your demonstration. Let's go back to the China Medical University Hospital, room 2. Hello.
Hello.
Kevin.
Yeah.
Yeah. Would you tell us your case?
Yeah. Is there a summary of the patient's history? The slide? Or no? Hello? Where is the slide? Hello? That's all right. Is a dialysis patient.
CTO of the right iliac artery, and this the right superficial femoral artery. Operator will be the Osamulidia. Osamulidia, and the assistant will be the Dr. Wang Junchen. This case of right innominate vein CTO, which was filled to PTA for 2 times. The operator will be the Xu Zhonghe, and the assistant will be the Lin Yukai, Dr. Lin, and the operator Kevin. It's an 88-year-old female with underlying hypertension, dyslipidemia, DM, and ESRD on hemodialysis. Her symptom is a right arm swelling for several months. Here is the angiography. Here we can see there is a central vein stenosis and no more flow towards the innominate vein. And our strategy will be the PTA and standing of the stenotic area. And maybe we will use the BBAC reentry device and IVOS assisted.
Anita?
The case number.
Kevin?
Yeah?
So what's your progress? What's the job you done?
Are you calling me?
Yeah.
You can call Ida because the history is Ida's patient. And Ida's diagnostic angio is also okay now. So do you want to see room 1 first?
So
the history
is room 1
you
ready?
just present. Yeah, it's room 1's case. Right iliac and SFA CTO by Ida.
Sorry, because room 1 is still on puncturing, so so keep on your job.
No. Okay. But Ida want to show how to puncture the right SFA because the right iliac artery is occluded. Maybe you should ask Ida.
Okay. Thank you. So we go to the room 1. Hello, Ida.
Hi,
Hello.
everyone.
So you want to show us your puncturing?
Yes.
Sure. Please.
This is This is the initial angiogram. As you can see here, the right external iliac occlusion with a good collateral coming from the hypogastric artery. The next one, please. Next. So we can see the next, please. Next. Previous one, please. No. So anyway, so I punctured the right common femoral artery under the contrast. Next, please. Yes. My assistant, Dr. Lee, and he injected contrast from the left contralateral sheath, and I punctured under the fluoroscopy guidance. Okay. Write this. Okay. I just started my procedure with why it doesn't work. So okay, Angel, please. So can you understand what I'm doing now? Angel, please. Angel. Please. Okay. This is my branch. I punctured another. It's okay. It's okay. It's okay. So blood is coming. So maybe the puncture site is not so good. I'm okay. Okay. So I will puncture again the upper side. Okay, upper side. Okay. Once again, please. Do you have any comment about the right femoral anterior puncture?
Anyone has any suggestion or comment?
Front, please.
I think there's two kinds of this kind of puncture. One is fluoroscopy guide. Another one is the echo guide. And the common femoral vessel is very big, so I think echo guide puncture is very easy for this.
Very easy. My assistant suggests me. suggest me. But I want to see the condition of the common femoral artery and the angio. That's why I challenge to puncture the right common femoral artery under contrast. But anyway, it failed. Yes, please?
And this puncture site is a little lower. You may
Little
be
lower, I know.
You may be
Again, yes.
Yeah, there
Okay,
is the
I'll try
lesion over there.
Okay, contrast again, please. Please inject.
Do you consider change a sharper needle? Because I think it is not a technique problem. I think your needle is too sound, so it is difficult to overcome the calcified plaque. So maybe you can try the micropuncture set, because the micropuncture set are okay. You did it.
I did it. Okay. 6 French, please. And a multi-purpose caster, please. So I have to finish my procedure within the 30 minutes because I have a presentation. Okay. I will insert the 6 French sheaths for the right common femoral artery, like this. Okay. Multi-purpose, please. And can I have a stiff telumo? Stiff one. So one discussion point is which type of stent should we use in this kind of an external iliac artery? So we have a balloon expandable stent and a cell expanding stent. We also have a cell expanding cover stent and also the BBX, like a balloon expandable cover stent. So what do you think about this point? Any suggestion for me? Okay. Okay. Very stiff.
Hello, Dr.
Any comment?
I'm Dr. Tsai from Chang'an. So I think the stenting is required in this part after orangeoplasty. But however, to put ordinary metal stent or to cover stent is a issue. So maybe I would suggest to do the IVUS after the angioplasty to see where are we? Are we in the septima or near the septima or in the center of true lumen, which will make our better decision for which stent should press.
Okay, Adele, hold on. Okay. JL caster, please. Yes, please. Sorry, I can't follow your comment, so please say again, please. Yeah.
Okay, Ida, please. I'm sorry. I want to that everybody knows these 2 case history first. So I will let the case presentation again first. Please give us the case presentation first.
A case of right innominate vein CTO, which was filled to PTA for 2 times. The operator will be the Xu Zhonghe, and the assistant will be the Lin Yukai, Dr. Lin, and the operator Kevin. It's an 88-years-old female with underlying hypertension, dyslipidemia, DM, and ESRD on hemodialysis. Her symptom is a right arm swelling for several months. Here is the angiography. Here we can see there is a central vein stenosis and no more flow towards the innominate vein. And our strategy will be the PTA and standing of the stenotic area. And maybe we will use the BBAC reentry device and IVOS assisted.
And you will give us the room 1 case presentation.
Of PAOD, CTO of the right iliac artery and distal right superficial femoral artery. Operator will be the Osamu Idia. And the assistant will be the Dr. Wang Junchen. This is a 15-years-old male with underlying dyslipidemia, hypertension, pancreatitis, and PAOD. He had catheterization in 2023. We noticed the CTO of the right iliac artery, which we failed to wiring. And his ABI is 0.57 and 0.77. Obviously, it's a case of PAOD. The symptom is intermittent claudication, even walking for 100 to 200 meters walking. Let's see the image. Maybe angiogram might be clearer. Here we can see there is a wire failed to pass to the internal left femoral artery, left internal iliac. Yeah.
Okay.
Right internal iliac artery.
So because of the section problem, thank you for your presentation. Let's go back to the room 2. Kevin?
Yeah.
Have you anything you want to say before we end this section? Because this is a lunch section, we must close this section.
Okay.
This
case already failed two times. Let's see the diagnostic angio. 第6个 round. 第5. 上一个. You can see the IL-30 and the LL 60 degrees. They are maybe about 4 to 5 centimeters dense. Right. 第4个 round, 上一个 round. It's a PA view and the true lateral view. So because this patient have a very swelling right arm, and but already failed 2 times in fact, even by the experts. So it's very common from our moderators and panel. Certainly, if today's plan is to penetrate with maybe double balloon or cut, reverse cut, and if it fails, we try to use a feedback reentry device.
So, Kevin, you go ahead to do your job, and maybe we'll close this section, and we will see the result on next section.
In the next section. Yeah. Okay.
Okay. So we go back to the room 1. Hello, Ida. I'm sorry, because of the time problem, so we have to leave this section. Maybe we'll see the your progress on next section.
Okay. Okay.
Okay. Sorry for that. So you continue your job. Okay.
Okay. Thank you.
Thank you. So we close that section. There's a lunch symposium. So
And,
maybe we'll close this section now.